Hello, everyone, and welcome to this free webinar presented by WePast. My name is Christina Ruiz, and I will be your moderator today. Throughout the webinar, we will stop the presentation to review. There will be several multiple-choice review questions which you will be able to answer in the polls section. Please go ahead and respond to these questions as they come up. You will have about a minute to answer each one. During the webinar, please feel free to use the chat to ask questions and discuss the topic. We will take time after the presentation to answer these. This and other recorded webinars will be available to WePast subscribers. You can register through WePast.com to become a subscriber. Today's topic is Radiation Protection and Quality Assurance for Therapy Certification Board Review, Part 2, presented by Frank Ascoli, Medical Radiation Physicist at US Oncology in Providence, Rhode Island. It's good to have you back, Frank.
Thank you, Christina, and welcome to everyone who's listening. This is the second half of the lecture series on registry review for radiation therapy. And topics that we're going to be discussing this evening are biological effects, the ALARA principle, radiation monitoring units, all of the different agencies that we are responsible to, exposure limits, sources of exposure, and there will be lots of questions at the end that I will be putting forth to help you prepare for the actual exam. I always feel that the best way to prepare for these tests is to get yourself familiar with lots of different questions and practice on many different questions. So that's what you will find toward the end of tonight's lecture. Let's start with a discussion of the ALARA principle. ALARA stands for as low as reasonably achievable. And if you look it up in the NRC regulations, it will say it's a commitment by the institution that is included in its license agreement. It's really an operational philosophy. And I'll explain that a little bit more after I go through the rest of the points here on the ALARA program. Training programs are required in the ALARA program, and investigational limits are set for radiation badge readings. An investigational limit typically is 10% of what's allowed. When you back calculate for a monthly allowed dose for a radiation worker, you find that that investigational 10% limit would probably be at around 40 milligram. If someone shows a badge reading of 40 milligram, it is really up to the radiation safety officer at that time to investigate what may have contributed to it. It may be perfectly normal reading and it may be perfectly explainable, but ALARA says that once you reach 10% of your allowed limit, the radiation safety officer should begin to ask some questions just to see if everything is okay with how you're wearing a badge, where you wear the badge, and the equipment that you're working with and the shielding of the sources that you're working with. So back to an operational philosophy. It's a goal to keep things as safe as reasonably achievable. Management and the radiation safety officer both combine their expertise to keep things as safe as reasonably achievable. And the key word is reasonably achievable. So an example I like to use is think of a radiation therapy vault that's shielded with anywhere up to 6 feet of concrete, sometimes 8 feet of concrete, depending upon the beam energy. Now, we all know that radiation has a half-value layer. All radiation has half-value layers, and the half-value layer for concrete could be around 18 inches of concrete. So for, say, a normal 6 to 10 MV X-ray beam. So we build this room, and we decide that we're going to put 6 feet of concrete to keep the outside area safe. Somebody says, well, why don't you make it a little bit safer and cut it down even a half again? So you add another 18 inches of concrete, add another 18 inches of concrete, add another 18 inches of concrete. And before you know it, you have a wall that could be 20 feet thick. and you still get a reading. So at what point does the radiation safety officer say, okay, it's safe enough? See, there really is no answer to that. There's no hard and fast answer to how much concrete or shielding to put in a wall, because you will always be able to measure radiation penetrating a barrier if you have a sensitive enough meter. So what is reasonably achievable? It's not reasonable to take up all of your real estate with concrete that lowers an already low number. So that's something that's decided by the radiation safety officer when he or she analyzes the situation. I can tell you that as a general design philosophy, we never, as shielding designers, we never design to the maximum allowable. We always design to probably 1/10 of what's required, and that is in keeping with the ALARA principle. Let's continue along this line and talk about radiation safety. And this is something I photoshopped. There really is no book called Radiation Protection for Dummies, but it really is a very simple formula for keeping yourself safe from radiation. And as you learned in your training, it's time, distance, and shielding. Those are the three things that you can do to lower your radiation exposure while you're working with radiation. Exposure is linear with time. Double the time that you're with a source of radiation, double your exposure. Half the time, half the exposure. That is a linear relationship. The one that I really like is distance. The intensity of radiation is inversely proportional to the square of the distance. As we talked about last evening, it's really a mathematical concept based on divergence from a point source. If you double your distance, you get 1/4 of the radiation. If you quadruple your distance, you get 1/16 of the radiation. So distance is definitely your best friend when it comes to radiation protection. Distance will give you the most protection, and it's because of the inverse square law. Of course, you can also add shielding, and radiation intensity is inversely proportional to the thickness of the shielding. So if you add more and more thickness, it's an inverse relationship to the amount of thickness added. You're adding half value layers, and you end up with half of a half of a half of a half as you keep adding half value layers. Or if you're adding 10th value layers, it could be a 10th of a 10th of a 10th. It just keeps going on, approaching zero, but never reaching zero. But the more shielding you add, the less intensity there is. The further you are away from a source of radiation, the less intense it is. And of course, the less time you spend around a source, the less radiation you will be exposed to. Radiation is regulated by both the federal government and the state governments. State governments are called either agreement states or non-agreement states. Excuse me. And it just means that they have agreed to act as the Nuclear Regulatory Commission within their state. Roughly 2/3 of the states are agreement states. They have decided not to have the federal government regulate their isotope and safety program. They have decided to do it themselves. They collect all the fees, and they have an agency, usually called the Radiation Control Agency, that takes care of all of the regulations. Now, they still have to meet the NRC regulations. They can do better than the NRC regulations, but they can't do worse than the NRC regulations. So there's definitely a swing toward agreement states where all of radiation safety and protection comes under one regulatory agency, as opposed to isotopes coming out under the NRC and X-ray equipment coming under the state. So does the NRC regulate all 50 states' radioisotope program? And the answer is no. They regulate roughly about 1/3 of the states, where these states are still non-agreement states. So they rely on the federal government to regulate the isotope program. Isotopes include anything that's used in nuclear medicine, iridium-192, cobalt-60, and some of the other isotopes that are used in medical radiation therapy. States which act as the NRC are called agreement states. That's true. Does the NRC regulate LINACs? This is really interesting. No, the state regulates LINACs because LINACs produce so-called man-made radiation. If you can unplug it from a wall, it is not reactor produced, and the state agencies will regulate linear accelerator radiation, not the Nuclear Regulatory Commission. The Nuclear Regulatory Commission actually has a very narrow scope of regulation, and its charge is only to regulate reactor-produced isotopes. They do not regulate linear accelerators. In radiation effects, we talk about two generic effects, and the terms that are used are stochastic and non-stochastic. The previous term for stochastic was genetic effect of radiation. The stochastic effect is a really interesting effect because it has no threshold and it's based on probability. And as the slide shows, the probability of the effect increases with increasing absorbed dose, while the severity is independent of the dose. So this is an interesting concept. These are the really bad things that we associate with radiation, such as genetic abnormalities and cancer. And what a stochastic effect is an effect which does not get more severe with more radiation. Cancer doesn't get worse with more radiation. Genetic defects that is acquired doesn't get worse because the individual was exposed to more radiation. The probability, however, of getting the effect increases with increasing dose. So this is a statistical problem where if more radiation is given, the probability of getting the effect is increasing, but the severity of the effect is not changed at all by the amount of radiation. So this is a stochastic, probabilistic, no threshold. In other words, no dose, absolutely there is no threshold. Every dose carries a small probability of producing a bad effect of radiation. That's the stochastic model. The non-stochastic model is a threshold and deterministic model. This is called a somatic effect. Radiation causes skin damage. Radiation causes skin reddening. The more radiation that's given, the redder the skin becomes, the more damaged the skin becomes. The same thing is true with all of the other things listed here. Organ atrophy, decreased germ cells, lens opacification, they all get worse with more radiation. So that is a non-stochastic threshold event because there is a threshold where the effect is seen. Small doses of radiation do not result in skin reddening, but large doses do. So there is definitely a threshold. This is very different from the stochastic model, which says that every dose carries a risk. In radiation biology, we like to talk about dose response curves, and this is really fascinating to analyze the different types of dose response curves that are out there that are talked about in the literature. The first curve is a curve which attempts to describe the effects of radiation as enhanced with low dose, but then tapering off and leveling off with high dose. So this is a theory that says the very low doses of radiation are extremely harmful and the higher doses may not be as harmful. That's what that bump in the beginning shows. Not a lot of people ascribe to this theory, but yet there is some literature out there that attempts to prove that this is true of radiation. This one is a generally accepted theory of radiation. This is the linear quadratic relationship. It starts at 0 very slowly and then starts to pick up steam and increasing in slope as the dose gets higher and higher. So low doses of radiation, not too harmful. High doses of radiation, very harmful. This is the linear quadratic model. This is what it looks like on a graph. This one is very interesting because it actually dips below 0 initially, crosses a threshold, and then becomes linear quadratic. So this is a linear quadratic. Not only does it have a threshold, but the fact that there is a negative bad effect means that there is a good effect. A negative bad effect is a good effect. So this is the theory of radiation hormesis, where a little radiation is actually good for you. A little radiation actually keeps the immune system tuned up. A little bit of radiation actually makes you a healthier person. There is an incredible amount of data that's out there that looks at low levels of radiation, such as what we're exposed to in radiation therapy. And the biggest study of all of radiation workers in the field of radiation is actually conducted by the ASRT, and it's currently going on with the University of Minnesota. It is a federally supported program. It takes very detailed history of radiation workers. There are probably over 180,000 radiation workers enrolled in the study, and it goes back many years. It goes back probably to the 1950s. And surprisingly, there were papers that came out recently that suggest that radiation workers actually do tend to live a little bit longer than their peer group that does not work with radiation. And some of that may be what's called the healthy worker effect. And by that, it's not so much the radiation, the way I think about it, but it may be the fact that you're not really at a desk job. You're getting up, you're moving patients, you're using your muscles. You probably walk about 2 miles in the course of a day, going from the control room to the treatment room. So you don't think of work as exercise, but you are getting a lot of exercise while you work. So there is a healthy worker effect with radiation workers, and it does fall into this kind of model. Very interesting, fascinating, but no one in their right mind would suggest that we go out and get radiation for practical purposes and for exam purposes. We need to use a linear no threshold model where every dose of radiation is harmful and it goes up linearly with no threshold. This is the safest model to use, a linear no threshold model, when we design radiation safety programs. I did skip through this one right here, and this is the linear quadratic with a more severe threshold dose. But for exam purposes and the ones that radiation safety officers and shielding design people use is a linear no threshold model where every dose of radiation is considered to be harmful. Regulatory limits are very important to know for exam purposes, and this is a list of the really important ones. An occupational dose limit in this country, it's different in Europe, it's a little less in Europe, but in this country it's 50 millisieverts per year, which comes out to be about 5 rem per year. In my experience, you can get 5 rem per year. You can probably get a little under 5 rem per year if you take the door off of a radiation therapy vault, if a maze. So you could actually take the door off a maze and probably still be under 5 rem per year at the control console. This of course is ridiculous. No one would ever suggest this, and no one designs to 5 rem a year. But this 5 rem a year has been a solid federal and state regulation for many years. It's never really been challenged. In spite of all of the studies that have been done and all the analysis that's been done on radiation safety and protection, and radiation gets examined a lot, probably more than any other environmental hazard. The 5 rem per year is a limit that is set with the thought that no harmful effects occur under 5 rem per year. There's just no documentation of this. But again, we design for 1/10 of this in practice, and no one designs for 5 rem per year, because you wouldn't have doors on X-ray rooms if you did that. The cumulative level is lower. It's 1 rem times your age. That is the most amount of radiation that you can get in a lifetime. If you're 25 years old, you're allowed to get 5 rem per year until you reach 25, and then you have to drop down to 1 rem per year. So the cumulative lifetime total is 1 rem times your age. Lens of the eye, currently at 15 rem, but there's a movement to make that lower. This is, again, a per annum dose. Skin, hands, feet, any other organ, thyroid, liver, lungs, 50 rem per year. I mean, these sound like high numbers, and they are. These are the current regulatory guidelines. For the general population, however, it drops way, 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 way down to 1 millisievert per year for the general population. So the thinking here is that the general population makes up 99% of the population. The other 1% is probably radiation workers. So that 1% we can limit to 5 rem per year, which we know to be a safe limit, but then to be ultra conservative safe, we are going to drop it way down for 99% of the population, and that goes way down to 0.1 rem per year, or 1 millisievert per year. And the general population, in fact, no one is allowed to get more than 2 millirem per hour. Never, ever, under any circumstances, can anyone receive more than 2 millirem in an hour. The embryo fetus limit is 5 millisieverts for the gestational period. This comes out to be under 50 millirem per month. So you see that the embryo fetus limit drops right down to 1/10 of the occupational limit. And as a general rule for radiation shielding and design, this is what we do today, is for a controlled area, such as a control room, a control booth, a control area where the radiation workers reside, that area gets designed to 0.5 rem per year. The general population in the surrounding areas, such as, let's say, a private office, or a waiting room, or a bathroom, or a corridor, any general population area, non-controlled, gets designed to 0.1 rem per year. So radiation controlled areas, the current recommendation is 0.5 rem per year. Thus, if anyone is pregnant in a radiation area, they are automatically covered by the limit. But the general population around that area, around that room, is limited to 0.1 rem. And this is how shielding design is done today. There's also plenty of radiation exposure to be had in the operating room, and this is an example of radioisotope iodine-125, and the same regulatory limits apply in the operating room. And if an operating room worker is badged, then that operating room person is considered a radiation worker. Once someone has a badge, they are considered a radiation worker, and they would come under ALARA, and they would come under the regulatory guidelines of 5 rem per year for occupational workers. But the ALARA principle, as I mentioned earlier, investigational limits are very low. 40 millirem per month is enough to trigger an investigation. It's hard to get a lot of exposure in the OR with these iodine seeds. Iodine has very low energy. They're pretty well protected. Once they're in the patient self-shields the radiation from the iodine. Very, very little radiation is emitted from an iodine implant. And in fact, these patients are totally free, if they feel like it, to leave the day surgery area that day and go out to dinner and a movie without a problem to anyone. The only stipulation on iodine-125 implant patients is that pregnant women living with the implant patient, small children living with the implant patient, do not sit directly on the patient's lap for up to 2 months, because in close proximity to the skin, there will be a detectable reading. But once you get about 3 feet or 4 feet away from an implant patient, it is very, very hard to pick up a reading with a Geiger counter. How long should personnel dosimetry records be kept? And the answer is usually indefinite. There's NRC regulations and there's state regulations. And in many states, the Radiation Safety Office requires that personnel dosimetry records be kept indefinitely. It happens sometimes where cases will go to litigation and records that were kept 30 or 40 years ago have to come out in discovery to prove one way or another that the radiation is a problem or not a problem. So personnel dosimetry records kept forever. That is, once exposure is given, it's permanent. And individual workers should know how much radiation they've gotten in their lifetime. Sometimes if a department closes up, the state will actually want to take custody of those records and put them in a archive somewhere. So conventional thinking on radiation records, keep them indefinite, and full annual calibrations of linear accelerators, cobalt machines, those should also be kept indefinitely. Machine maintenance records, lifetime of the machine, and then they can be destroyed. Newly installed source, such as a cobalt source or an iridium source, those probably should be kept indefinitely in case there is any question at all years later as to the accuracy of the source activity and the dose that was delivered. We will be talking a lot about TG40, TG142, constancy checking, monthly checking, yearly checking, and daily spot checks that therapists do every morning. Those can be kept for 3 years and then disposed of. Terminology for radiation areas come in different terms, and one of them is called restricted area. It's an area access to which is limited. So a restricted area would be the control area. Doesn't include residential quarters. You can't, because there's a bedroom in an office building nearby, that and the radiation levels are high, you cannot say that room has to be restricted. That's just not allowed. But a restricted area has to be reasonably associated with a radiation area. A controlled area, same thing. It's an area outside of a restricted area, but inside the site boundary, access to which can be limited by the licensee for any reason. So this could be a fence around a linear accelerator to keep people a certain distance from the walls. That would be a controlled area with a fence around the LINAC room. So there's three different definitions I want to go over, and one of it depends upon the level of the intensity of the radiation. One is called a radiation area. Radiation area is accessible to individuals if that person can receive 0.005 rem or 5 millirem in 1 hour. Then at 30 centimeters, that is considered a radiation area. A high radiation area is if an individual can receive in excess of 0.1 rem or 100 millirem in 1 hour at 30 centimeters. That is a high radiation area. And the areas that we work in, linear accelerator vaults, are considered very high radiation areas because someone in that vault can easily get in excess of 500 centigrade in an hour at a meter. So vaults are always considered high radiation areas. When physicists do radiation shielding design, it is critical to take into account the actual occupancy of the room being protected. So for example, a control area is always occupied by therapists. So that has an occupancy factor of 100%. Control areas are always 1. But corridors where there's transient foot traffic, people come and go along the corridors, and it's not always the same people, those can be downgraded to only 20% occupancy. Exam rooms are not always full 8 hours a day with the same people. Occupancy can be lowered to 1/2. Bathrooms, 1/20. Outdoor, if there's an outdoor parking area and patients come and go every day, that has a very low occupancy because the same person is very unlikely to get radiated 8 hours a day, 40 hours a week. So the occupancy factor that is always part of a shielding calculation takes into account how long can the same person get the radiation in the area surrounding the radiation room. So for a therapist at a control area, it's obviously 100% because the therapist is there treating patients 8 hours a day, 40 hours a week. That's 100%. Not the case with a parking lot outside. So as a result, shielding thicknesses do vary depending upon what surrounds the room. And this goes for both therapy centers and diagnostic centers. A question that always comes up, especially after implants, is when can a patient be released from the hospital? And the guidance is very clear on this from the Nuclear Regulatory Commission, and these state agencies have picked up the same wording. A member of the general population cannot receive more than 500 milligrams. That is the rule. So someone can be released from the hospital as long as the physicist, the radiation safety officer, can calculate that that person in the course of a normal day, even living with spouse and people in the house, that no one can receive more than 500 milligram. And this is based on this is the Nuclear Regulatory Commission has come up with model factors to put into this equation based on how many hours a day and at what distance people tend to really hover and sleep together and eat together and whatever. It turns out with iodine 125Cs, when you back calculate, you find out that at 3 feet, it has to be less than 0.15 ml per hour, and that's easy to attain with iodine 125 because the patient self-absorbs. With cesium-131, you see, as we spoke yesterday, cesium-131 has a very short half-life, 9.8 days, 9.7 days. So its radiation is given off at a much faster rate. And to complete decay, which would occur a lot quicker than in the case of iodine, at 3 feet, the patient must be less than 6 ml per hour because the cesium-131 seeds give off their radiation a lot faster, so they present more of a hazard to people in the household. But if in the operating room you're getting less than 6 ml per hour at 3 feet from the patient can be safely released. And in my experience with cesium-131 prostate implants, generally at 3 feet from the patient, you're in the order of about maybe 3 or 4 ml per hour. So it's very, very rare that a cesium-131 patient would exceed 6 ml per hour at 3 feet. So cesium-131 patients, just like iodine 125 patients, can be released on the same day. The Nuclear Regulatory Commission has come up with terminology for medical events. We call these unintended deviations. We call these misadministrations. The new terminology is medical events. And these are the factors that go into a medical event. Total body dose, organ dose, shallow skin dose generally apply to nuclear medicine, diagnostic X-ray. But here is the part that applies to radiation therapy. If at the end of a course of treatment, the patient dose differs by 20%, that could be 20% in either direction, either plus 20% or minus 20%, it classifies as a medical event. If a single fraction SRS treatment differs by more than 50%, that is a medical event. If the wrong patient is treated, obviously a medical event. The wrong route of administration doesn't pertain to radiation therapy, and the wrong drug doesn't pertain to radiation therapy. But the ones that would pertain to radiation therapy, the total dose differs by more than 20%. There's also another rider on that says the weekly dose can't differ by more than 30%. These are reportable to the state regulatory agencies. The state or the NRC, if it's a non-agreement state, has to be notified within 24 hours. What makes it really painful too is that the referring doctor needs to be notified within 24 hours that the doctor's patient has received a misadministration. The patient certainly has to know within 24 hours, but there are situations where the patient doesn't have to be told. And that situation is explained usually by a patient who is mentally so unstable, for lack of a better word, that if you tell the patient that something went wrong, the patient will absolutely quit treatment, not come back for treatment at all. And even though if it was an event which the doctor feels won't affect the outcome of the treatment, and it, just by telling the patient would harm the patient and make the patient not come back to treatment or cause mental harm to the patient, then that information can be withheld as long as the referring doctor is informed about the misadministration, and certainly a written report as to what happened within 15 days to the reporting agencies. Switching gears a little bit, environmental protection. So we spoke about radiation protection. There is the other side of protection in a department, and it has to do with mechanical, electrical, magnetic effects, magnetic hazards, right to know law, MSDS sheets, and emergency situations. So we're going to spend a little bit of time talking about the non-radiation hazards that exist in a department. So here is the first webinar question for the group. Therapy clinic located near or under high voltage power lines, do patients receive extra radiation dose? And your answers are A, yes, or B, no.
All right, so go ahead and head over to the polls section where you can answer this question live, and we'll be going over the answer in just a few moments. Okay, Frank, I think everyone's had a chance to put their answers in.
Okay, the answer is no, resoundingly no. The radiation, the electromagnetic radiation given off by power lines is EMF, electromotive force. It does not ionize things. The radiation given off by power lines, electromotive force, radiation, magnetic lines of force do not ionize. Radiation dose that we are concerned with has to be ionizing radiation. It has to be quanta, it has to be photons, it has to be packets of energy that behave as both waves and particles that have the ability to knock off electrons in the material being bombarded by radiation. So in order to qualify as a radiation dose, it must be ionizing radiation. Lots of things to worry about in a therapy room besides the radiation, and I've listed here a number of things that I've thought about that we are all exposed to in the course of a working day. There's radio frequency from the klystron and the magnetrons. There's electromotive force from the high voltage. Ozone is produced when the machine is producing radiation, say during testing, commissioning phase, and it's running for literally hours. There is a small amount of ozone, O3, that's produced in the room by the ionizing radiation. That is an occupational hazard. Sulfur hexafluoride is an insulating gas for the waveguide, and it will displace oxygen, and that's bad if there's a sulfur hexafluoride leak in the room. Phosgene gas happens when sulfur hexafluoride is hit by high voltage arcing. Phosgene gas is mustard gas, very, very hazardous. Electric shock, these machines underneath the fiberglass covers and the metal cages, which have high voltage warnings on them, these machines have up to 25,000 volts on exposed contacts. So there's electric shock hazards. Of course, there's collisions. There's falling parts. We always put things onto collimators that could fall off and hurt the patient if we're not careful. Radiation causes plastic to deteriorate. Deteriorated plastic is brittle. It breaks, it cracks when it's bent and stressed. That is a hazard with long-term radiation exposure. Some surfaces within the machine get very, very hot. Electric fire, I've observed a couple of times, if solenoids get stuck and current is still passing through them, there's actually smoke pouring out of the machine. And at that point, you hit the main circuit breaker and call the physicist. Laser beam, not a terrible hazard. These are quarter milliwatt lasers. They really won't do any harm, but they still come with a warning not to stare at the laser beam directly. And software integrity is always, always, always a problem. Is this software communicating correctly? Is it really telling the multi-leaf leaves where to move correctly? So these are just some of the precautions, and I'm sure that you can even think of more things that are hazardous in the room that we deal with on a day-to-day basis. I mentioned ozone, and in a room design, the HVAC people will always design for at least 10 exchanges per hour, 10 full air exchanges per hour. That gets rid of the ozone that's produced from the bombardment of high energy radiation with the oxygen in the room air. And it also gets rid of any airborne radioactive material that is produced by the neutron contamination that we spoke about yesterday. Neutrons can make things radioactive. Sometimes gases are made radioactive from the neutrons. There's outgassing of radioactive gases from the different parts within the machine. And 10 exchanges per hour keeps the room safe from a respiratory standpoint. And we're all familiar with pacemaker patients, and that magnetic fields can be harmful to pacemakers. These are a couple of graphs provided by Varian, which show that magnetic fields actually vary with gantry angle, and that makes sense because sometimes as the gantry rotates around, things move in and out of the way, and gets closer to the earth through the reinforcing steel in the walls and the floor, changes the magnetic field surrounding the machine. Just as an aside, pacemaker patients generally kept below 200 centigrade. Magnetic fields are a hazard to pacemakers, but modern pacemakers have become very well shielded to magnetic fields, and it's really ionizing radiation today that we worry about the most. The sensitive circuitry within a pacemaker can be damaged at levels above 200 centigrade. Sometimes 500 centigrade, depends on the device, but certainly if the pacemaker is within 3 centimeters of the radiation field, it needs to be measured for how much dose it's going to get and possibly moved to a safer location if the patient has to undergo a course of radiation that will compromise the pacemaker. So what to do if certain things go wrong in the room? If a treatment beam fails to terminate, there's crash buttons everywhere. They're on the console, they're in the room, they're on the couch. Hospital power fails, you've got to get the patient off the couch. You need to know how to use emergency pendants. Fire, smoke, gas, again, crash button, main circuit breakers. The main circuit breakers are always located near the console area, very, very handy nearby. When in doubt, crash the machine. Ask questions later. Here is another webinar question. What is Lipowitz alloy commonly called? Okay, Christina.
All right, if you would just give us some of those options. I think you have.
Of course, you're waiting for me. You know what?
No worries. It's
there was a lag. Okay. Sorry about that.
It's okay.
Okay, liquid gold, Saraband, janitor in a drum, CAD-free.
All right.
So what's commonly called?
The poll question is up, and you can head over to the tab just to the right of the chat and go ahead and answer this question live before we go over the correct answer. All right, so it looks like most people are getting the correct answer.
Okay,
and
great.
If you would go ahead and go over it.
That answer is Saraband. Saraband is a eutectic alloy. You can impress people at a cocktail party by throwing out that word. It is a eutectic alloy. The components of Saraband are lead, tin, cadmium, and bismuth. Together, they make an alloy that melts at a very low temperature, way lower than the melting point of any of the constituents of the alloy. So it's a eutectic alloy. The hazardous material in Saraband is cadmium, which is a carcinogen, and lead, which is a neurotoxin. Cadmium and lead are the two culprits in Saraband that make it bad for you. But a misnomer out there, and a lot of state agencies haven't gotten this straight yet. When you have a pot of Saraband in a room, there is nothing volatilized. There are no hazardous gases coming off of Saraband. It doesn't produce any hazardous gas. If you put it in a fume hood, all you're going to get is regular air coming out of that fume hood. It doesn't volatilize lead. It doesn't volatilize cadmium. It's all bound up in the Saraband. There are no hazardous fumes that come off of Saraband. However, people are moving slowly away from Saraband. and using material like copper instead to make electron blocks. And certainly Cerebend has been replaced for pretty much mainstream radiotherapy by multi-leaf collimators. This is an example of a very easy to read MSDS sheet. Every compound used in the department should have an MSDS sheet in case something goes wrong. And if you take the time to read the MSDS sheet, you will get all the information that you need to know, including special precautions and protective information, et cetera, et cetera. I think when all is said and done, I mean, I've had people request MSDS sheets for Lysol spray in the bathrooms. I mean, that's just nuts. But in a radiation therapy department, it's really the Cerebend that deserves an MSDS sheet. While I said it's not volatile and it doesn't become airborne and there's no breathing hazard, if you file blocks, certainly Cerebend dust is bad for you. If you breathe in Cerebend dust, it's bad for you. If you get Cerebend dust on your fingers and then eat a chicken salad sandwich without washing your hands, very bad for you. You don't want to ingest this stuff. So all of that's included in an MSDS sheet. The MSDS sheet is actually part of a regulation called the Right to Know law. Every state has one. And the Right to Know law says that you, the radiation worker, or any worker for that matter, has a right to know common names, hazard levels, symptoms of exposure, potential flammability, emergency treatment, safe use, protective equipment, cleanup procedures, and have the Department of Labor phone number prominently posted in the break room so anyone can call if they have a concern about occupational hazards, not radiation. So the Right to Know law is the equivalent of the radiation protection laws that we abide by. There is the other part of working in a radiation department having to do with non-radiation hazards, and the Right to Know law covers that. Okay, moving to the next topic. Theory and operation of linear accelerators and the production of radiation. I'm going to play this a couple of times because this is how linear accelerators produce radiation. So you have a gun, and the gun is a filament. The filament glows red hot and emits electrons. The electrons are accelerated through a series of cavities and are made to slam into a tungsten target. I said yesterday, when electrons slam into a tungsten target, they produce Bremsstrahlung, braking radiation in the forward direction. That's what those arrows show. It's called a transmission target. The electrons hit it on the backside. Bremsstrahlung radiation comes out the front side. So not like a beveled target in an X-ray tube. Very, very different. Transmission target. Electrons are accelerated at near the speed of light, passing through a series of cavities, slam into a piece of tungsten. Now, how do you get electrons to accelerate? Well, if you change the polarity of that cavity, see, at just the right time, as the electron passes through that little hole in the middle, if you change the polarity of it at just the right time, you can push the electron with a negative voltage and pull it and attract it with a positive voltage. And the only way to switch a cavity that quickly, so you can get electrons traveling at near the speed of light, is to use something at the speed of light. So we use microwave. Microwave switching plus and minus, plus and minus, plus and minus extremely rapidly phases those cavities just at the point where a bunch of electrons entering a hole sees a high negative part of a curve, sees a high negative part of the curve, and it's repelled, while the other end of the cavity sees the high positive part of the curve, and it's attracted. And the electrons travel through not as a steady stream, but as a bunch, as a cluster of electrons, push, pull, push, pull, push, pull, push, pull, switching with the microwave. So some people like to think, it's like an electron riding a surfboard. That's not quite the same, but if it helps, sure, think about it that way, no problem. The point is that the electrons get very, very fast, almost the speed of light, like 0.99 the speed of light, 0.9999 the speed of light. The longer they're accelerated, the closer to the speed of light they become. They are relativistic particles. I mean, what other field can you work in where you're working with relativity and antimatter, and you're using it on patients. Amazing, absolutely amazing. So relativity at work here. This is relativistic quantum mechanics at work in your linear accelerator, producing very high energy Bremsstrahlung radiation. A LINAC breaks down into certain key components. The electron gun is the source of electrons. The accelerator is the 4-foot long tube that actually does the acceleration with a series of cavities. Of course, you have to have a magnetron or a klystron to pump the microwave into the accelerator. So that's the job of the magnetron or the klystron. And the modulator is what causes the magnetron and the klystron to work effectively. And the modulator also pulses the electron gun so that the bunch of electrons hits those cavities at just the right point in time where they undergo push, pull, push, pull, push, pull. If the phase of the microwave is off even a little bit so that the electron doesn't arrive at that central aperture at just the right point when the voltage should switch from minus to plus, the electrons will not get accelerated and the machine just sits there and hums and you get an undervoltage fall. So phasing, radio frequency control, automatic frequency control, all very, very important. 3/4 of the machine is nothing but a microwave generator. Once the electrons hit the target and radiation is produced, then you have the beam shaping and beam control mechanisms that we're going to talk about in a little while. Support systems include water, vacuum, air, and gases. And in your daily warm-up procedure, many times you're asked to take some basic readings on these just to make sure that the machine is in tip-top shape. As machines become more and more sophisticated, though, they're self-diagnostic and they will tell you when they are not happy, and they'll actually give you an error code that you can give to the service engineer who can probably tunnel in with a remote computer connection and even fix things remotely for you. This is the anatomy of a linear accelerator. On the left is the beam path, and you see the cathode, which has the filament, the source of electrons, the accelerator guide that accelerates the electrons, and then the electrons enter the bending magnet of the machine, which takes the beam and directs it back down toward the patient. The beam has to pass through a flattening filter. Well, that used to be the case, but now we have FFF, flattening filter-free beams, where the flattening filter is removed, but generally the beam passes through a flattening filter to make it nice and uniform across, and then it passes through the very important ion chamber, which is going to help with the readings and the output. To treat the patient with electrons, the X-ray target is removed. So why are bending? This is not a webinar question. This is these are the questions that I like to throw out to the audience to get them all in shape to answer board questions, registry questions. Why are bending magnets needed above 6 MV? And the answer is because the accelerator cavity is too long to be mounted in the beam direction. You have to get the beam heading 90 degrees back down toward the patient. But here is a webinar question. What does a bending magnet bend? Does it bend photons or does it bend electrons? A or B?
So the poll is up. Go ahead and answer this one, and you'll have a little less time since it's only a couple options. So go ahead and put your answers in, and we'll go over the response. All right, Frank, do you want to give us the answer?
Answer is electrons. You can't bend photons. Photons are not charged, and they generally don't react to magnetic fields unless it's something the size of a star. So it won't happen in a linear accelerator. We don't bend photons. Is the bending magnet a source of radiation? Absolutely. Electrons that don't make it around the magnet slam into the walls and release heat and Bremsstrahlung radiation. That's why that bending magnet is heavily, heavily shielded. Does the bending magnet need water cooling? Absolutely, because of the heat generated from the electrons slamming into the walls, the bending magnet has to be cooled. The ion chamber, very important device. Not only does it measure the output of the machine, but it also measures symmetry and flatness, which are two important characteristics of the radiation beam. And the way it does that is by splitting the ion chamber in half and comparing the top half to the bottom half and the left half to the right half. So there's basically 4 quadrants being monitored by the ion chamber, giving feedback to the linear accelerator about how symmetrical that beam is. Here's a quick picture that shows you what the ion chamber looks like. And this is the ion chamber assembly right here, deep in the head of the machine. And of course, this is the multi-leaf collimator that we're all familiar with. These are the vanes of the multi-leaf collimator. Sometimes people want to know about multi-leaf collimator leakage. Interleaf leakage is about 2%. And overall transmission is less than 1%, which is way better than Sarabande blocks. Symmetry and flatness, 2 very important concepts for physicists when they're commissioning a machine. The example on the left here shows a beam which is very symmetrical. If you take the area in the left under the curve and compare it to the area in the right under the curve, they're equal. So that is a symmetrical beam. Left equals right. However, Twin Peaks here, very unflat. So this is not a flat beam, but a symmetrical beam. That's not so much of a problem because a treatment planning computer can be modeled to represent this and show accurately what's going on in the patient. This is a much worse situation on the right. This is a beam that is flat, but not symmetrical. And this means that the beam has been missteered. And the treatment planning system will assume that the beam is symmetrical about the central axis, but the actual radiation treating the patient is not symmetrical. And that could be a very dangerous situation. So flatness and symmetry monitored quite often in a radiation therapy department. Quick word about CT simulators. CT simulators not only give you the shape and size of the patient for treatment planning, but also give you the important CT number, which can be corrected for heterogeneity of the patient. So the simulator is a very important part of the treatment planning process. You've got the shape of the patient, the thickness, the organs that are all assigned values for organs at risk, but also CT numbers in the background, which correct the dose distribution for the heterogeneities within the patient. And here's an example of some of the fancy tattooing that we do here in Providence for localization. We've got a very talented group of therapists here, and they get a little carried away with their tattooing. Quality assurance procedures. We want to talk about two guides, TG40 and TG142. Yesterday I mentioned TG stands for Task Group of the American Association of Physicists in Medicine. And these are reports that are basically how-to cookbook reports, how to test a linear accelerator, how often should you test it, and what are you looking for. So this goes back to the goal to deliver radiation therapy within 5%. This, long time ago, International Council on Radiation Units, International Council Radiation Units said that we can't tolerate 7%, 10% changes because that affects tumor control. The goal today is definitely to keep tumor doses and organ at-risk doses within 5%. That is a challenge. That is a challenge because tumor localization itself has an uncertainty. Immobilization or lack of carries an uncertainty. The field placement has an uncertainty. There are human errors in calibration, minor errors. There could easily be up to a 2% error in calibration just because of the equipment, and we don't even know it. Calculations sometimes are prone to error, although not as much anymore because of computerization. As you are well aware, daily patient setups, not always the same day to day, and sometimes equipment-related problems. So when you start doing the square root of the sum of the squares and try to come up with an overall error, take all of these into account and try to keep the result within 5%. No trivial feat to do, and requires lots of care, lots of attention, and lots of expertise to do that. So acceptable mechanical tolerances for simulators, usually 2 millimeters. These are conventional simulators. I don't even know why this is up here anymore. Very few people use conventional simulators. TG40 is the most comprehensive QA recommendation cited by state agencies, includes simulators, cobalts, and Linux. And as I said, gives you frequency, tolerances, and what to look for. So here are the money slides. On a daily basis, X-ray constancy should be within 3%. In other words, the output day-to-day should not vary by more than 3%. That's for daily warm-up. That's for daily checking. That's not for physicists. Physicists are kept monthly to a stricter percentage, but daily can be up to 3%. Lasers within 2%, ODI within 2 millimeters, and the door interlock and the audio-visual controls absolutely have to work on a daily basis, or you cannot treat the patient. Here's an example of some daily test devices that you may be familiar with. So here's some webinar questions: to treat or not to treat. This is a whole series of questions. So we're going to go through it one at a time. This may take a few extra minutes. Daily dose checker outside established tolerances. So you run your daily checker and it is outside the established tolerances. What do you do?
All right, so this one is up in the polls already, so go ahead and take a moment to answer it, and then we'll go over the response. All right, Frank?
The answer is no. Don't treat until you talk to the physicist. Do not treat till you talk to the physicist. Call the physicist up, get him out of bed, talk to him. If it's outside of 3%, you want to know that it's okay to treat. If it's outside of 5%, hopefully he or she will get up and come into the department and measure the machine stat. What if your lasers are off by 3 millimeters? Treat or no treat?
All right, this one is also already up. It looks like people are going ahead and putting in their answers. So why don't we go over the correct answer?
That's a yes. You can go ahead and treat, because we don't really care about lasers anymore. It's a suggested starting point. Image guidance today, really the norm in departments. KV imaging, cone beam CT imaging, and motion management systems, surface contour management systems are the norm in most departments today. So the lasers can be off by 3 millimeters. You can go ahead and treat as long as you have good image guidance. Table shifts. In the morning, you're testing your table shifts off by 5 millimeters on a test cube. What to do? Yes or no?
All right, this one is also up in the polls, so go ahead and put your answer in, and we'll go over the correct one in just a moment.
Let me jump in, just in the interest of time here. Table shifts off by 5 millimeters. I would not treat until, again, you had confirmation by the physicist, because a 5 millimeter shift remotely, where you can't even see what's going on after you've imaged the patient, that's pretty significant. If the shift is off by, this is a controlled shift on a cube. If it's off by 5 millimeters, something is wrong in the analyzing software or in the actual table mechanism. TV camera not working, but you can hear the patient. You can't see the patient. Yes or no?
All right, you can go ahead and answer this one.
That is a definite no. If you can't see the patient, you cannot treat the patient. How about room interlock not working? Door interlock. You test the door interlock and it's not working, and you think, well, that's okay. I'm standing right here by the door. No one's going to go in and out of the room. Should you treat the patient or not? Door interlock not working.
All right.
That's a no. You will be in big trouble with the federal government and the state government if you treat with a non-working door interlock. It doesn't matter if your control panel is right there beside the door. Door interlocks have to work or legally you cannot be treating the patient. It's been 3 days. The physicist hasn't double-checked the chart yet. What do you do? Yes or no?
Okay.
I'm going to say no to that. I think definitely the chart has to be checked within 3 days. Those are the accrediting agencies. The American College of Radiology, ASTRO, everybody agrees. The chart has to be double-checked within 3 treatment days. Something could be wrong, and you could be making a serious error if you don't do that. So at that point, I would just stop. And this is actually a good chance to put a royals in on the physicist and just say he or she hasn't checked the chart yet. And that'll shake them up pretty good. No written directive. Yes or no?
All right, this is our last one, I believe.
Yes.
So go ahead and
that is a
put your answer in the polls.
No. Oh, I'm sorry. I gave the answer away already.
That's okay.
That's a definite no. Do not treat without a written directive. Bad things will happen. Bad things will happen. Do not treat without a written directive. Okay, so TG40 for Linux. This is monthly by the physicist. So monthly, the physicist tests output, photons, electrons, checks the energy, checks flatness and symmetry, checks all the safety interlocks, and makes sure all the mechanical tests are working. So this is not daily for the therapist. This is monthly for the physicist. And annually, the physicist does a full calibration. That's a total shakedown of the machine, almost like a mini commissioning every year, with a full report that is available for state regulators to inspect and also for the American College of Radiology or ASTRO or ACRO to inspect. There has to be a full annual calibration by the physicist every year, or your department will not get accredited. TG142 came out in September 2009, and it added imaging devices and some of the other things that weren't checked in TG40. Portal imagers have to be tested monthly by the physicist. KV imagers by the physicist. Cone beam CT image quality by the physicist. You may actually be incorporating some of this in some of your daily checks, depending upon your policy and procedure in the department that you're working in. And they also differentiated TG142, which was like an addendum to TG40, made the criteria more strict for SRS and SBRT machines because the stakes are very high with single dose or hypofractionation. So the tolerances are even tighter for SRS machines. 1 millimeter shifts, if it's going to be used for SRS, it has to be within a millimeter for SRS. Low output is the norm now with intensity modulated radiation therapy. The machine is burping off 2, 3, 4 MU at a time. And is that output as good as the 100th monitor units that's typically checked for in the morning or by monthly by the physicist? Do you have the same constancy of output for low MU? Are the ISO centers the same for the KV imager and the MV treatment head? The KV imager has its own ISO center. I know it's connected to the gantry, but it does have its own ISO center. Does the KV imager ISO center match the treatment beam ISO center by 1 millimeter for SRS machines? And here's a quick table that shows some of the differences. If a machine has the ability for cone beam CT and it's used for SRS, it has to be within 1 millimeter. CT simulators, not a lot to do on a monthly basis, a daily basis. Some departments require the therapist to run a uniformity test to make sure that the ounce field unit for water is consistent. Monthly, some physicists do a test of CT number for the different density plugs that are in a CT phantom. And those are acceptable tests for the CT simulators. So how often must charts be checked? And again, these are just going to be questions that I'm going to be popping off over here. Weekly chart checking. By whom? By the physicist. There's been a lot of clarification here. Some centers use the dosimetrist with physicists to check charts, and compliance people that I have to deal with say you can't do that anymore because the coding, you can't get paid for that weekly code unless the chart is checked by a physicist. End of treatment check absolutely has to be done by the physicist and within a week. So if there's a problem with the treatment, it can be corrected in a timely fashion. The initial chart calc, the second check on the initial calc should be before the third treatment. If it's hypofractionated, it really needs to be done before the very first treatment. I find as I go around and look at different departments that pretty much everyone is second checking charts now before the first treatment. I very rarely see people waiting until the third treatment to do a second check on a chart. Here's a few more questions. Do you have to check flatness and symmetry daily? No, you don't, but the QA devices today usually do, and the physicist certainly checks it monthly. Neutron contamination, greater at 20 MV or 20 MeV. Well, of course it's 20 MV. X-ray, electrons don't make neutrons. High energy X-rays do. Sealed sources, leak tested. So this is a sealed source, not iridium, because iridium gets changed every few months. But if a sealed source like cesium-131 or radium is going to be used, it has to be tested at a certain interval. Is it every 2 years? True or false? False. It has to be tested every 6 months. So a reusable source like cesium or iridium, I'm sorry, not scratch that, cesium or radium has to be tested for leaks every 6 months if you're going to continue to use that. Iridium, like I say, doesn't have to be leak tested because it's changed every 3 months. So that eliminates the need to leak test it. Cerebellum blocks, less transmission. True or false? That's false. They allow more, usually about 5% through cerebellum. And here's a few more questions. Average energy, these are real tough physics questions. So how much energy is actually lost per ion pair in a typical Compton interaction? And the answer, as you all know, is 35 eV, and the unit is called a W, 35 eV per ion pair. So think about that. You have a beam that has photons up to 6 or 10 or 15 million volts, and every ionization is expending 35 eV. There are a lot of ionizations that occur in a radiotherapy beam. What are the units of linear energy transfer? I did go over this yesterday. One of the participants asked a very good question about LET, and it's keV per micron, kilo electron volts per micron. So it's a measure of how quickly the beam interacts and is absorbed. What is the average range of a 4 MeV alpha particle? And it is amazingly little, 37 microns. So alphas, as big as they are, they're the Mack truck of radiation. Alphas are huge particles, 2 protons, 2 neutrons, heavily, densely ionizing. They don't penetrate our dead layer of skin. They can't get through the dead layer of skin that we all carry around with us. However, alpha particles ingested, like the case of the Russian that was poisoned with plutonium, alpha particles ingested are a terrible, terrible hazard because the alpha will destroy living mucosa everywhere in the body. But you could have a pound of an alpha emitter sitting in front of you. It is not a hazard. If you eat a little bit of it, you're dead. P32 is a beta emitter. What is the energy? Nobody uses P32 anymore, so I'll probably take this one out in the future, but for you, the nerds out there, it's 1.7 MeV. P32 has a beta energy of 1.7 MeV. And actually, historically, I go back a ways, this was used for the treatment of ovarian cancer. It was actually, put into the patient's peritoneum, and the patient was rolled around side to side, so the P32 would coat her peritoneum, and it would hopefully eradicate cancer cells that were floating around in the fluid within the patient's peritoneum. We don't do that anymore. APBI, brachytherapy. Some of you have seen Accelerated partial breast brachytherapy. Saline-filled balloon placed in the lumpectomy cavity. What is the typical depth for that? And it is 1 centimeter, always 1 centimeter from the balloon surface. Minimum skin to balloon distance, 5 millimeters, but 7 is recommended. Under 5 millimeters, recommendation is really not to treat unless you can prove that the skin dose with some of these multi-lumen catheters is acceptably low. But typically, you want at least 5 millimeters to the skin, from the balloon to the skin surface. Maximum dose per hour outside the HDR room, remember the magic number, 2 MR per hour. No one anywhere can ever receive more than 2 MR per hour, period, end. You can't get more than that in your occupation, or it is not legal. An area survey, however, shows that you're standing outside the HDR room and you're getting 2.5. Wow, I just said you can't get more than 2 MR per hour, but you're getting 2.5 on the meter. That's okay, because the treatment takes less than 48 minutes. So the 2 MR per hour means that in any 1 hour, you can't get more than 2 MR. If the treatment's only 5 or 10 minutes, even though it's a 2.5, you're not going to get 2 MR in that hour unless you do 10 patients back to back, and that's not going to happen. So yes, a reading can be over 2 MR per hour, but you can't get more than 2 MR per hour. Percent depth dose of 250 kVp orthovoltage is always 100%. For superficial orthovoltage, skin dose is always 100%. But this one's interesting, 6 MeV electrons. What's the skin dose with 6 MeV electrons? And surprisingly, it's less than 80%, which is why bolus is usually prescribed for 6 and 9 MeV electrons, but not for higher energy. It's just the opposite of what you would think. Higher energy electrons have higher skin doses than low energy electrons. 20 MeV electrons, same choices, 90%. Why? Lateral scatter from the higher energies. The higher energies have more lateral scatter, and the electrons are scattering back to the surface. The patient is treated at 300 centimeters with 6 MV photons. So this is extended distance. Does it still keep the same Dmax? And the answer is no. As you move the patient further and further away from the source of radiation, the Dmax actually starts creeping toward the surface because of all of the contaminant, electrons, X-ray, junk in the air that reaches the patient from the high energy radiation. A lot less of a Dmax at extended distances. Percent depth dose, however, this is really dosimetry and not radiation protection. Percent depth dose always increases with distance. Always, always. PDD always increases with distance from the target. So how much contamination is acceptable in an electron beam? I mentioned that yesterday, 5% or less. What's the typical frequency of microwave used? Throw this one out at a cocktail party. Your klystron is putting out 2.7 gigahertz. It's not really the low end of microwave. It's not the high end of microwave. It's the low end of microwave, 2.7 gigahertz. And that 2.7 gigahertz just happens to have a wavelength of 10 centimeters, which just happens to be the length of the accelerator cavity. These cavities are about 10 centimeters long, and the wavelength of 2.7 gigahertz is about 10 centimeters. That is not a coincidence. 10 centimeters. X-ray, however, the X-ray in angstroms is 0.001 angstroms. So the X-ray that's produced is extremely energetic and very short wavelength. Light radiation field alignment must be tested monthly by the physicist. Sometimes therapists test them weekly or monthly. If the physicist asks them really nicely, sometimes the therapist will test light field, radiation field for them. But TG40 says it has to be done monthly, so that usually means the physicist. Mechanical isocenters are tested annually. Mechanical isocenters. Now, I know a lot of this gets tested daily, but the requirement is just annually on mechanical isocenters. And right to know law lectures have to be given annually. And I think that finishes the lecture. So we have some time for questions. Go ahead, Christina.
Okay, great. So here's our first question from Carol. Is there a predominant interaction with matter that takes place during brachytherapy?
Okay, so Carol, brachytherapy. Brachytherapy involves usually iridium-192, and the predominant interaction at iridium-192 would be outside of the photoelectric effect and into the Compton effect. So the answer, I would say, for iridium is Compton effect. However, let's think of another brachytherapy source that we use. Iodine-125 has an energy analogous to mammography, 25 keV. At 25 keV, it's mostly photoelectric. So in the end, you can argue dose is dose, whether it's a photoelectric interaction or whether it's a Compton interaction. In either case, the electron has been ejected. In one case, in the photoelectric effect, the electron is ejected, but it doesn't go anywhere, and there's no scattered radiation. That's the photoelectric effect. In the Compton effect, the electron is ejected, travels a couple of centimeters, and the resultant scatter travels in the forward direction. So in the end, dose is dose, and it doesn't matter how you get it. But I would say the predominant reaction for iridium is mostly Compton. Yesterday, we said photoelectric on the low end, Compton in the middle end, which is mostly therapy. And then at the very high energies, like above 25 MeV, you start to get pair production. Next question.
Okay, so I think this might be a comment on that from Kurt. Compton is the dominant interaction from approximately 0.03 MeV to 25 MeV for soft tissue.
Mm-hmm. Okay.
And I think that's the last one, unless anybody has any other questions or comments. All right, I think that's it for tonight. Thank you so much for presenting this webinar, Frank, and thank you all for joining us for this free event hosted by WePast. This and other recorded webinars will be available to WePast subscribers. You can register through wepast.com to become a subscriber. For up-to-date information about upcoming webinars, be sure to follow WePast on Facebook, Twitter, and Google+. All right, thanks again, everyone, and we'll see you next time.